Good morning. It's Tuesday, November the 24th, and this is The Drill. Thank you. The prayer of the day comes from me. Dear Lord, please open the eyes of faux conservatives. Please let them escape from the cult of neutrality so they can freely walk, talk, act, and speak like true conservatives. Amen. Welcome to all the butchers, bakers, and candlestick makers out there. I'm Ron, your host, and the only true conservative in the United States today. Who is the true conservative? First and foremost, he's realistic. Secondly, he's God-fearing. The true conservative is the man who follows his plan. He's appropriate. He's the person that has the courage of his convictions and is confident in what he knows. He's the person that subordinates politics to reality. He's not selfish, but minds his own business. He acts like an adult. He's patriotic and uses common sense. He is judgmental and moralizes. He refuses to speculate, speaks clearly and definitively, and is not afraid to say no. He's open-minded, asking why rather than why not. He's consistent, credible, and influential, not ashamed of his existence, unafraid to learn or correct his mistakes. He's a normal American, and he's better than the socialist. He's a better friend, father, brother, family member, and a better person, period. And you have to know that. Being a true conservative is best, or you are wasting your time. Additional examples of what it means to be a true conservative can be heard by listening to John Cobalt and Ken Champeau on The John and Ken Show on KFI AM 640, Monday through Friday from 2 to 6 p.m. Pacific Time. My podcast is short, approximately 5 to 20 minutes long, because shorter podcasts are easier to download and listen to. And the biggest socio-political influences of my life are my parents, my teachers, Hugh Hewitt, Glenn Beck, Rush Limbaugh, Sean Hannity, Dennis Prager, Buck Sexton, Joe Pags, The Enlightenment, Ayn Rand, and Dr. Mortimer Adler. My podcast is made available through Spreaker and can be heard on iTunes, Spotify, Google, and YouTube. I can be reached at thedrill12@gmail.com. Today, a sensible and compassionate anti-COVID strategy, which is an article written by Jay Bhattacharya for the Imprimis newsletter published by Hillsdale College. So, let's see. Jay Bhattacharya is a professor of medicine at Stanford University, where he received both an MD and a PhD in economics. He's also a research associate at the National Bureau of Economics Research, a senior fellow at the Stanford Institute for Economic Policy Research, and at the Freeman Spogli Institute for International Studies, and director of the Stanford Center on the Demography and Economics of Health and Aging. A co-author of the Great Barrington Declaration, his research has been published in economics, statistics, legal, medical, public health, and health policy journals. So the following is adapted from a panel presentation on October 9th, 2020 in Omaha, Nebraska at a Hillsdale College Free Market Forum. My goal today is, first, to present the facts about how deadly COVID-19 actually is. Second, to present the facts about who is at risk from COVID. Third, to present some facts about how deadly the widespread lockdowns have been. And fourth, to recommend a shift in public policy. The COVID-19 fatality rate, number one. In discussing the deadliness of COVID, we need to distinguish COVID cases from COVID infections. A lot of fear and confusion has resulted from failing to understand the difference. We have heard much this year about case fatality rate of COVID. In early March, the case fatality rate in the U.S. was roughly 3%. Nearly 3 out of every 100 people were identified as cases of COVID in early March. And those people that got that died from it, so 3%. Compare that today when the fatality rate of COVID is known to be less than 0.5%. In other words, when the World Health Organization said back in early March that 3% of the people who get COVID die from it, they were wrong by at least one order of magnitude. The COVID fatality rate is much closer to 0.2 or 0.3%. And the reason for the highly inaccurate early estimates is simple. In early March, we were not identifying most of the people who had been infected by COVID. Case fatality rate is computed by dividing the number of deaths by the total number of confirmed cases. But to obtain an accurate COVID fatality rate, the number in the denominator should be the number of people who have been infected, the number of people who have actually had the disease rather than the number of confirmed cases. In March, only the small fraction of infected people who got sick and went to the hospital were identified as cases. But the majority of people who are infected by COVID have very mild symptoms or no symptoms at all. These people weren't identified in the early days, which resulted in a misleading fatality rate, a highly misleading fatality rate. And that is what drove public policy. Even worse, it continues to sow fear and panic because the perception of too many people about COVID is frozen in the misleading data from March. So how do we get an accurate fatality rate? To use a technical term, we test for seroprevalence. In other words, we test to find out how many people have evidence in their bloodstream of having had COVID. This is easy with some viruses. Anyone who's had chickenpox, for instance, still has that virus living in them. It stays in the body forever. COVID, on the other hand, like other coronaviruses, doesn't stay in the body. Someone who's infected with COVID and then clears it will be immune from it, but it won't still be living in them. What we need to test for then are antibodies or other evidence that someone has had COVID, and even antibodies fade over time, so testing for them still results in an underestimate of total infections. Seroprevalence is what I worked on in the early days of the epidemic. In April, I ran a series of studies using antibody tests to see how many people in California's Santa Clara County, where I live, had been infected. At the time, there were about 1,000 COVID cases that had been identified in the county, but our antibody tests found that 50,000 people had been infected, i.e. there were 50 times more infections than identified cases. This was enormously important because it meant that the fatality rate was not 3%, but closer to 0.2%. Not 3 in 100, but 2 in 1,000. When it came out that Santa Clara study was controversial, this Santa Clara study was controversial, but science is like that, and the way science tests controversial studies to see if they can be replicated. And indeed, there are now 82 similar seroprevalence studies from around the world, and the median result of these 82 studies is a fatality rate of about 2.2%. Exactly what we found in Santa Clara County. In some places, of course, the fatality rate was higher. In New York City, it was more like 0.5%. In other places, it was lower. The rate in Idaho was 0.13%. What this variation shows is that the fatality rate is not simply a function of how deadly a virus is, but is also a function of who gets infected and of the quality of the healthcare system. In the early days of the virus, our healthcare systems managed COVID poorly. Part of this was due to ignorance. We pursued very aggressive treatments, for instance, such as the use of ventilators. That, in retrospect, might have been counterproductive. And part of it was due to negligence in some places. We needlessly allowed a lot of people in nursing homes to get infected. But the bottom line is that the COVID fatality rate is in the neighborhood of 0.2%. So, 2, who is at risk? The single most important fact about the COVID pandemic in terms of deciding how to respond to it on both an individual and a governmental basis is that it is not equally dangerous for everybody. This became clear very early on, but for some reason our public health messaging failed to get this fact out to the public. It still seems to be a common perception that COVID is equally dangerous to everybody, but this couldn't be further from the truth. There's a 1,000-fold difference between the mortality rate in older people, 70 and up, and the mortality rate in children. In some sense, this is a great blessing. If it was a disease that killed children preferentially, I, for one, would react very differently. But the fact is that for the young children, this disease is less dangerous than the seasonal flu. This year in the United States, more children have died from the seasonal flu than from COVID by a factor of 2 or 3. Whereas COVID is not deadly for children, for older people it is much more deadly than the seasonal flu. If you look at studies worldwide, the COVID fatality rate for people 70 and up is about 4%. 4 in 100 among those 70 and older, as opposed to 2 in 1,000 in the overall population. Again, this huge difference between the danger of COVID to the young and the danger of COVID to the old is the most important fact about the virus. Yet it's not been sufficiently emphasized in public health messaging or taken into account by most policymakers. 3. Deadliness of the lockdowns. The widespread lockdowns that have been adopted in response to COVID are unprecedented. Lockdowns have never before been tried as a method of disease control, nor were these lockdowns part of the original plan. The initial rationale for lockdowns was that slowing the spread of the disease would prevent hospitals from being overwhelmed. It became clear before long that this was not a worry. In the U.S. and most of the world, hospitals were never at risk of being overwhelmed. Yet the lockdowns were kept in place, and this is turning out to have deadly effects. Those who dare to talk about the tremendous economic harms that have followed from the lockdowns are accused of heartlessness. Economic considerations are nothing compared to saving lives, they are told. So I'm not going to talk about the economic effects. I'm going to talk about the deadly effects on health, beginning with the fact that the UN has estimated that 130 million additional people will starve this year as a result of the economic damage resulting from the lockdowns. In the past 20 years, we've lifted 1 billion people worldwide out of poverty. This year, we're reversing that progress to the extent, it bears repeating, that an estimated 130 million more people will starve. Another result of the lockdowns is that people have stopped bringing their children in for immunizations against diseases like diphtheria, pertussis, and polio because they had been led to fear COVID more than they feared these more deadly diseases. This wasn't only true in the U.S. 80 million children worldwide are now at risk of these diseases. We had made substantial progress in slowing them down, but now they're going to come back. Large numbers of Americans, even though they had cancer and needed chemotherapy, didn't come in for treatment because they were more afraid of COVID than cancer. Others have skipped recommended cancer screenings. We're going to see a rise in cancer and cancer death rates as a consequence. Indeed, this is already starting to show up in the data. We're also going to see a higher number of deaths from diabetes due to people missing their diabetic monitoring. Mental health problems are in a way the most shocking thing. In June of this year, a CDC survey found that 1 in 4 adults between 18 and 24 had seriously considered suicide. Human beings are not, after all, designed to live alone. We're meant to be in company with one another. It is unsurprising that the lockdowns have had the psychological effects that they've had, especially among young adults and children who have been denied much-needed socialization. In effect, what we've been doing is requiring young people to bear the burden of controlling a disease from which they face little to no risk. This is entirely backward from the right approach. Number 4, where do we go from here? Last week, I met with 2 other epidemiologists, Dr. Sunetra Gupta of Oxford University and Dr. Martin Kulldorff of Harvard University in Great Barrington, Massachusetts. The 3 of us come from very different disciplinary backgrounds and from very different parts of the political spectrum. Yet we had arrived at the same view, the view that the widespread lockdown policy had been devastating, a devastating public health mistake. In response, we wrote and issued the Great Barrington Declaration, which can be viewed along with the explanatory videos, answers to frequently asked questions, and a list of co-signers, etc., online at www.gbdeclaration.org. The declaration reads, quote, "As infectious disease epidemiologists and public health scientists, we have grave concerns about the damaging physical and mental health impacts of the prevailing COVID-19 policies and recommend an approach we call focused protection. Coming from both the left and the right and around the world, we have devoted our careers to protecting people. Current lockdown policies are producing devastating effects on short and long-term public health. The results, to name a few, include lower childhood vaccination rates, worsening cardiovascular disease outcomes, fewer cancer screenings, and deteriorating mental health, leading to greater excess mortality in years to come, with the working class and younger members of society carrying the heaviest burden. Keeping students out of school is a grave injustice. Keeping these measures in place until a vaccine is available will cause irreparable damage, with the underprivileged disproportionately harmed. Fortunately, our understanding of the virus is growing. We know that vulnerability to death from COVID-19 is more than 1,000-fold higher in the old and infirm than the young. Indeed, for children, COVID-19 is less dangerous than many other harms, including influenza. As immunity builds in the population, the risk of infection to all, including the vulnerable, falls. We know that all populations will eventually reach herd immunity. In essence, the point at which the rate of new infections is stable, and that this can be assisted by, but is not dependent upon, a vaccine. Our goal should therefore be to minimize mortality and social harm until we reach herd immunity. The most compassionate approach that balances the risks and benefits of reaching herd immunity is to allow those who are at minimal risk of death to live their lives normally, to build up immunity to the virus through natural infection, while better protecting those who are at highest risk. We call this focused protection. Adopting measures to protect the vulnerable should be the central aim of public health responses to COVID-19. By way of example, nursing homes should use staff with acquired immunity and perform frequent PCR testing of other staff and all visitors. Staff rotation should be minimized. Retired people living at home should have groceries and other essentials delivered to their home. When possible, they should meet family members outside rather than inside. Comprehensive and detailed list of measures, including approaches to multi-generational households, can be implemented and is well within the scope and capability of public health professionals. Those who are not vulnerable should immediately be allowed to resume life as normal. Simple hygiene measures such as hand washing and staying home when sick should be practiced by everyone to reduce the herd immunity threshold. Schools and universities should be open for in-person testing. Extracurricular activities such as sports should be resumed. Young, low-risk adults should work normally rather than from home. Restaurants and other businesses should open. Arts, music, sports, and other cultural activities should resume. People who are more at risk may participate if they wish, while society as a whole enjoys the protection conferred upon the vulnerable by those who have built up herd immunity. I should say something in conclusion about the idea of herd immunity, which some people mischaracterize as the strategy of letting people die. First, herd immunity is not a strategy. It's a biological fact that applies to most infectious diseases. Even when we come up with a vaccine, we'll be relying on herd immunity as an endpoint for this epidemic. The vaccine will help, but herd immunity is what will bring it to an end. And second, our strategy is not to let people die, but to protect the vulnerable. We know the people who are vulnerable, and we know the people who are not vulnerable. To continue to act as if we do not know these things makes no sense. My final point is about science. When scientists have spoken up against lockdown policy, there have been enormous resistance. You're endangering lives, they say. Science cannot operate in an environment like that. I don't know all the answers to COVID. No one does. Science ought to be able to clarify the answers, but science can't do its job in an environment where anyone who challenges the status quo gets shut down or canceled. To date, the Great Barrington Declaration has been signed by over 43,000 medical and public health scientists and medical practitioners. The Declaration thus does not represent a fringe view within the scientific community. This is a central part of the scientific debate, and it belongs in the debate. Members of the general public can also sign the Declaration. Together, I think we can get on the other side of this pandemic, but we have to fight back. We're at a place where our civilization is at risk, where the bonds that unite us are at risk of being torn. We shouldn't be afraid. We should respond to the COVID virus rationally, protect the vulnerable, treat the people who get infected compassionately, develop a vaccine. And while doing these things, we should bring back the civilization that we had so that the cure does not end up being worse than the disease. And that was A Sensible and Compassionate Anti-COVID Strategy by Jay Bhattacharya in the, it's the October 2020 issue of Imprimis, which is a publication of Hillsdale College. Back in a minute. Thank you. The reason I was reading this article was because it's a sanity check. I always say, know what's real, ask yourself how do you know, and ask yourself what to do about it. So this is a what's real article. You hear a lot of crap on the radio and the television. People who aren't subject matter experts or specialists, that's the word I prefer to use, are spouting their opinions all over the place, politicians, governors, etc. So it's nice to have somebody that is a specialist in this area present some clarity. Present us with some clarity so that we can, again, for the sake of sanity, know what's real, and then from there we can, and he went ahead and explained why it's real and know what to do about it. He even gave recommendations on what to do about that reality. So, on the next episode of The Drill, why conservatives have not been defeating liberals. And that concludes another episode of The Drill. Be honest, be smart, be beautiful, and always ask yourself, what is real? How do I know? And what should I do about it? I'm Ron, and that's The Drill.